Alright folks, I think we're going to get started. Welcome. I see some familiar and new faces. For those that you know, Johnson, Gene, I'm one of the hepatologists here in the Division of Liver Diseases, and I'm the co-director of the Liver Seminar Series, or Conference Series, with my partner in crime, Augusto Villanueva, who helps with the sort of basic science talks and things like that. So for the new fellows, welcome. This is the start of our summer lecture series. With the purpose of it is to introduce you to faculty and sort of topics that are familiar to you, but maybe with a different sort of perspective, so you get comfortable in sort of meeting everybody and going through these talks. I think apropos to you guys taking a call, Dr. Chang, program director, is going to give us a talk on acute liver failure, something that you guys all know, and it still gives us faculty palpitation.
All right. So we wanted to start off with a useful topic. Welcome. So we try to put core essential topics into our summer lecture series, and you'll definitely see acute liver failure when you're on service, when you're on call. If we have time at the end, I'll go through some case discussions, and like the case discussions are all like real cases within the past like few months here, so definitely see it. And I want to just kind of go through some of the literature, guidelines, and also practical advice for how to approach these patients. You field a lot of transfer calls, so a lot of the management even starts with the first time you get the phone call, because there's a lot you can do over the phone, talking to the referring doctors, sending off appropriate tests to get to a timely diagnosis, because sometimes early interventions can even make the difference between even avoiding liver transplant in some instances. So here's an outline. First and foremost, we need to be on the same page about how we define acute liver failure. And UNOS has a different definition than the sort of clinical way that we diagnose acute liver failure. I want to spend a lot of time going through the differential diagnosis of causes. There are acute insults that can lead to liver failure that are best managed with a liver transplant, whereas there are other conditions that can also cause liver failure that aren't necessarily managed with liver transplant, like malignancies, for example, or ischemic hepatitis. It's important to go through prognostic predictors. You want to know when is a transplant going to help someone, when is it better not to transplant. So we'll spend a lot of time on these. And then we'll go through aspects of clinical management, which is largely intensive, largely ICU care. Okay. Fortunately, we have our new transplant ICU here, and these intensivists and the fellows are very comfortable managing these patients in the ICU setting. We also have neurointensivists who also come to the ICU. So there's a lot of team support managing these patients because they're so critical and complicated. A lot of this talk comes from guidelines. The last AASLD position paper was 2011. It's been a while ago, but there's a recent EASL update, so I'll direct you to the EASL guidelines. They were published in 2017, and it's actually a really good read. So if you have time, go through that, the EASL guidelines. I think probably a reason the guidelines haven't been updated for a while is it's such a rare condition that there's not a lot of rigorous studies out there. And so as such, I apologize, but you're going to see me kind of going back and forth between different slides. Where you see this sort of slide set comes from the EASL guidelines. There's a slide set that's available. And the guidelines, of course, go by grade of evidence. So grade 1, randomized controlled trials, of which there are really basically none. Most of the data comes from controlled or cohort studies. And of course, the grading of recommendations, either 1 strong recommendation or 2 weaker recommendations. So I'll be referring back to the EASL guidelines. And then here at Sinai, we have our own protocol, which is a fulminant liver failure checklist. and that's what I've handed out to you guys. It's available through the intranet. So if you go to RMTI, all the protocols are here, including like HCC monitoring post-transplant, the consent form to accept Hep C positive organs. So this is a really useful website for you guys to refer to. And if you're kind of coming in at the middle of the night, and you just want to pull it up online, this is a handy reference spot. Okay, so clinical definition of acute liver failure. This is a good house staff thing to do on rounds. It's a triad. So you need coagulopathy, you have to have encephalopathy, and it's important that this occurs in a patient who has no underlying chronic liver disease. So duration less than 26 weeks, and you'll find slight variations in this duration depending on what literature you look at, but 26 weeks, 28 weeks in other literature. But you need to fulfill these three criteria. Importantly is encephalopathy, okay? Acute on chronic liver failure is a completely different entity. We see that it has a very similar presentation, coagulopathy, encephalopathy. However, it's a completely different entity and with a different kind of prognosis. So it's important that you establish that this is not a patient who has underlying cirrhosis. Physical exam, you want to assess for physical exam stigmata of chronic liver disease, spider angiomata, and absence of signs of portal hypertension. The caveat being that there are cases of acute liver failure that can lead to parenchymal collapse, and so on imaging you can see a shrunken or small liver. This can happen in cases of autoimmune hepatitis, even drug-induced liver injury. So don't be fooled by imaging. Even presence of ascites can be seen in particularly subacute cases.
Can you explain the exceptions a little? Why, in what sense are those exceptions, and why are they exceptions?
So Wilson's disease, these are patients who have chronic liver disease, but when they flare, they have a universally poor outcome without transplant. And physiologically, they behave like acute liver failure fulminant patients. I don't know that the exact mechanism is completely understood. Autoimmune hepatitis, similarly, they have a overwhelming immune response, a lot of cytokines circulating around, and so physiologically they can behave like fulminants, although all along they may have had some chronic liver disease, albeit not quite cirrhosis. And then the Hep B flares are really tricky because these are patients who can have Hep B for decades, for a good part of their lives, not have cirrhosis. They may even have some degrees of fibrosis, but when they flare, they can behave like fulminants. And that can be a bit of a tricky thing that we deal with as a team when it comes time to listing these patients, how we list them as a status 1.
Charissa, can you comment on the fellow's grades of encephalopathy that are required to meet the definition? Because if you look at the definition, something I talked about past a lot, is that while it's quite sensitive, the bar is sort of set low to meet these criteria because you hate to miss something like this. Now, INR 1.5, everyone has that with cirrhosis, right? So in terms of encephalopathy, there's just understanding about how severe that is to be.
Right. So any degree of encephalopathy, we'll get to this when we talk about management, but when these patients become encephalopathic, they can go south very quickly. So at the earliest sign of encephalopathy, these patients need to be listed as status 1A. I don't know that it's well borne out in the literature, but the EASL guidelines allude to this, and I think we've all seen this anecdotally, is the subacute patient, particularly autoimmune or these DILI cases, and they kind of smolder along. Their numbers look horrible. They're coagulopathic, but they just don't have encephalopathy, and you want to list them, but you can't. And so there's some argument that these are patients who should be able to be listed and prioritized without the without meeting the classic definition of encephalopathy, or maybe it's just that we need more sensitive ways to assess for encephalopathy. But that's a really good point that you're raising, Jean. So any degree of encephalopathy. Yeah, okay. So for UNOS listing purposes, the encephalopathy needs to be within 8 weeks of onset of the first symptoms of liver disease, meaning this is all new, again, as distinguishing between patients who have acute or chronic liver failure, again, absence of pre-existing liver disease, and they need to be in the ICU, either intubated with INR over 2. I don't know why the INR is 2 for the UNOS criteria, a little bit higher. Some of these autoimmune patients can have they can look bad with an INR of 1.8, but then they turn around. So, maybe it's just setting a higher bar. And either requiring dialysis or CVVH. It's important for status 1 listing that they have to be in ICU. So the step-down bed doesn't count. So when you want to list these patients, you have to move them over to the ICU. The TICU is very accommodating. They will get patients over. We had a lady recently. We'll get to this if we have time for cases, who we actually preemptively put her in the ICU, knowing that she was about to develop encephalopathy, because at the end you don't want to be scrambling around just because of a bed situation. So really low threshold to put these patients in the ICU. Okay, so why does this give us palpitations? It's because the mortality is so high. This is somewhat older literature, but it just shows you outcomes of acute liver failure from the acute liver failure study group. Again, this is a rare condition, and so you need multi-center studies to generate data. And so you can see of patients who presented with acute liver failure, more than half either died without transplant or needed a liver transplant. So the spontaneous survival is less than 50%. This is more recent data. This is a study which might be interesting to go through at a journal club. It's in this month's hepatology, and it basically it looks at mortality on the waiting list for status 1A patients versus patients with acute on chronic liver disease. I'm not going to go into that study, but just out of this study, we have some more recent data on status 1A outcomes. So this is mortality at 14 days for patients listed as status 1A, and so over half ended up getting transplanted, but 20% died without transplant. So the mortality on the waiting list is 20%, and there is a small subset who do get listed, but they eventually survive without transplant, and that's something that we try to emphasize to the fellows and as a team, that we want to work up and list these patients in an expedited manner. If they start to get better, we can always delist them, but you can't transplant a patient if they're not listed. There's a lot of regional variation in the waiting time to transplant, and I have to say, I used to think status A meant they got to the top of the list and they would get transplanted in 24 to 48 hours. But if you actually look at median waiting time to transplant, it's actually dismally long for some of them. So we're here in region 9, and the median waiting time to transplant for patients listed status 1A is actually 10 days. So it's a long time. Many of these patients will not survive that waiting period, which is why you see this mortality rate. I'm surprised it's not higher.
But that's very different than waiting time, I'm guessing, for chronic liver disease.
It's much shorter. It's much shorter.
But the regional is made wise.
Yeah.
In region 1, it has almost 24 days.
Yep.
And I don't think region 1 has the longest wait times for chronic liver disease, does it?
No, and I think it may have something to do with organ availability. So, I mean, region 1 is, I don't know.
Northeast.
Yeah, northeast. And I think Leona will go through this in her talk when she talks about liver transplantation, but the proposal to change the distribution, instead of these randomly allocated regions, but to go by that's 250-mile radius, I think would even, in theory, even this out a lot. So, but I think it has to do with organ availability.
I think another way to put it is if you have, if you meet the criteria for status 1 and acute liver failure, your life expectancy is about 7 days or less. So if your numbers are higher than that median, a lot of people are not taking it.
Right. It's scary.
And you would assume the outcomes are different based on the waiting time, but that's not necessarily true either.
Right, that's true. Yeah, I mean, if you're waiting longer, then you develop renal failure, end up on dialysis. That worsens your outcome after transplant. Absolutely.
Or sometimes they spontaneously survive.
Yeah.
Crazy cases every once in a while that happens, where you have no choice but to see the natural history of disease and remarkably the difference.
Yeah. Yeah.
Not a good chance to take, but sometimes happens.
Right. So the prognosis, there's different ways of thinking about prognosis, and one of them depends on the type of presentation. So we can subclassify these cases into hyperacute presentation, and these are the ones where the onset is within a week. The classic case is Tylenol toxicity. These patients can present with severe coagulopathy. They don't have quite as much bilirubin elevation, and these patients tend to survive spontaneously without transplant. The ones that do poorly are these subacute presentations that kind of smolder along with onset over a few weeks. They tend to have higher degrees of jaundice, and their survival without transplant is poor. Also, we were talking about this just now with encephalopathy. It's the hyperacute cases that tend to have more incidence of cerebral edema as opposed to the subacute cases. So there's a whole laundry list of different things that can cause acute liver failure, a broad differential diagnosis. The viral causes are hepatitis B, A, and E. Remember, C doesn't usually lead to acute liver failure. CMV can coexist with drug-induced liver injury. Sometimes we see that, just some like mild CMV, PCR elevations, but really the cause is DILI. Herpes, zoster virus, toxins, including mushroom poisoning. Oops, come back up here. Drug-induced liver injury is a really important cause. We'll discuss this a little bit more. Vascular causes, Budd-Chiari. Pregnancy, the ones that lead to liver failure are preeclampsia, HELP, which are on the same spectrum, fatty liver of pregnancy. And then there's Wilson's disease, autoimmune. The red ones are, what I've listed here in red, are conditions that can cause secondary liver injury and aren't necessarily well managed with a liver transplant. So shock liver, malignancies like lymphoma, HLH, which can be associated with infections.
No delta?
I guess that kind of falls along with the B. So yeah, delta superinfection and B, yeah, that's true. If you look at different regions of the world, there's a lot of differences in what the causes of liver failure are. So this comes from the EASL guidelines. Although the data is somewhat old, this is basically just a summary of all the different publications out there that report differences in etiology. And so in the US and UK, acetaminophen is by far the most common cause of acute liver failure. And also Australia. If you look in Europe and Canada, it's viral and indeterminate. So there's big differences. Rob, maybe Canadians are happier or something. And then in India, 70% viral, 44% caused by hepatitis E. So there's a lot of differences. It's important to know this, just because we have a large immigrant population here in the U.S. So don't overlook hepatitis. In the New York area. So don't overlook hepatitis E. Okay, so if you divide out the causes of drug-induced liver injury, so in the U.S., Non-Tylenol drug-induced acute liver injury is about 13%. So most of the drug-induced liver injury is Tylenol, but among the other kinds of drugs that can cause acute liver injury, it's a long list. I'll highlight isoniazid. So these are non-Tylenol causes of DILI in the U.S. And isoniazid is one of the kind of more serious culprits. The anti-epileptic drugs, Dilantin, valproate, and then antibiotics, also because antibiotics are just used so commonly. PTU is here. Statins, although statins get a bad rep, and we generally think they're safe in liver disease, they can, in rare cases, lead to acute liver failure. And even NSAIDs have been associated with acute liver failure. This is a somewhat old study, but I like to refer to it. This comes from the Acute Liver Failure Study Group. And what I want to highlight here is how different etiologies have very different prognosis in terms of spontaneous survival versus need for transplant. So this is cases of acute liver failure from the U.S. Acute Liver Failure Study Group. And what you see, if you start first with the bars, this shows you a number of cases based on etiology. So again, Tylenol is the #1 cause of acute liver failure. Next, indeterminate. Next, non-Tylenol drug. Next, hepatitis B, although this number is much lower now that we have effective antiviral agents for hepatitis B. Autoimmune hepatitis. And the black dot here shows you transplant-free survival rate. So the good news is that although Tylenol is the #1 cause of acute liver injury, the transplant-free survival rate is over 80%. So these patients tend to do well without transplant. The ones that don't do well are Wilson's disease. So we talked about this just now. The drug-induced liver injuries have a low transplant-free survival rate. Indeterminate causes. So it's the DILIs and the ones where we can't find a cause that really scare me. Same thing with autoimmune hepatitis.
So it seems, except for DILI, that the causes that probably do have an underlying liver disease, like Hep B, autoimmune, Wilson's, those are terrible looking.
Yeah.
So it probably is acute on chronic.
Yeah.
As far as survival, and the ones that are truly acute, like acetaminophen and shock and Hep A, where you don't have an underlying liver disease, the survival is much better.
Yeah. Maybe we're misclassifying them.
Yeah, it looks like it.
It's possible. Yeah. And I think there's going to be more recognition that some of these acute on chronic liver failure patients don't do well, and again, I didn't go into the study, but may even do worse than some of these fulminants, and maybe we need to be thinking about these patients and prioritizing them differently. So in the EASL guidelines, they do distinguish between hepatic or primary causes of acute liver failure versus secondary causes, and again, that these secondary causes, it's important to diagnose them and identify them early because these are not the patients you should be listing and transplanting. Okay, so when you're doing your initial assessment, history taking is really important, not only from the patient and family members in front of you. Often they're encephalopathic and they're not going to be able to provide a history on their own. You're going to be getting history from family members, but also when you're getting that phone call from the referring facility. So you want to try to find what's the etiology. Have they been using any medications? Don't forget to ask about herbal use, any history of substance abuse, any mushroom use. When I was a GI fellow, we had a patient who came in with Amanita mushroom poisoning, and he worked on a golf course and was like driving around and picked up mushrooms and made a nice spaghetti sauce with the mushrooms for dinner.
It's quite common upstate New York.
Is it?
Foraging for mushrooms.
Oh yeah.
Also in the Bay Area, we once had a whole family that went mushrooming, and
Wow.
there were 4 patients listed for transplant.
Wow. Did they need transplant or did they survive? They did.
Actually, there's a case of that in the past year. From the Bay Area.
Oh wow. Yeah. So
So you'll see it.
yeah. but you won't know unless you ask. So remember this in the history taking. Of course, pregnancy is very important. Here in the New York area, ask if the patient has had any recent travel to areas that where Hep E is prevalent. Are they on immunosuppressive therapy? This is vis-a-vis hepatitis B reactivation, any underlying autoimmune disease. And then there are questions about, is liver transplant feasible? Is listing them as status 1A the right thing to do? So any prior history of chronic liver disease. Many times referring facilities will call over and say, I have an acute liver failure patient, but in reality it's acute on chronic in a cirrhotic patient. Any alcohol or drug use, any recent cancer, and any other major comorbidities that would preclude liver transplantation, so severe heart disease or other medical comorbidities. And then what's the interval between the onset of jaundice and the onset of encephalopathy? Again, helping you to kind of categorize these patients into hyperacute versus subacute presentations.
Charissa, you mentioned something important, which the fellows face a lot, which is a call from the outside hospital.
Yeah.
What should trigger transfer versus watchful waiting and continued communication with the outside hospital?
Yeah. Well, any encephalopathy, immediate transfer. Even consideration of intubating the patient before they come over here. Rising INR. Any of the patients who meet the King's College criteria, we'll go through those. So who have those poor prognostic signs.
Right.
Sometimes the Tylenol cases, they call you early on, and then they do some serial labs, and they already start coming down without any INR elevation. But I mean, we have a low threshold to transfer these patients.
Yeah, probably if it's on a Friday where the patient is not going to get looked after in another hospital.
Right.
Also.
Absolutely. We run into really tricky problems once the patient becomes hemodynamically stable and they start going on pressors.
Unstable.
Unstable, and they go on pressors, and then transporting the patient safely becomes a concern. So get the attending involved, because even as attendings, we struggle with these cases. You want to bring them over, but they need to survive the transport also. Okay, so these are the initial labs to send off, and I kind of think about the lab workup as labs that you send for diagnosis, labs that you send for prognosis, and labs that you need for management purposes for transplant listing. So the diagnostic labs, and these are the labs you may want to even kind of read over the phone to the referring facility. Tox screen, viral markers for Hep A, Hep B, Delta if they already have B, Hep E, and then the Hep C RNA and antibodies. Not so much to look for Hep C as a cause for acute liver failure, or more just to understand if this patient has underlying chronic Hep C. Tylenol level, ceruloplasmin may or may not be helpful. Sometimes it's low in non-Wilson's causes of acute liver failure, pregnancy testing, autoimmune markers. And then the labs that help for prognosis are your INR, some of the labs that you get from your comprehensive metabolic profile, like your renal function, lactate level, arterial ammonia, your pH on ABG, and then there are coagulation factors that are produced by the liver, which, if they're low, are a poor prognostic sign. So low fibrinogen, low factor V. High alpha fetoprotein is a good sign. It's a sign of liver regeneration. And then there's the management types of labs to send off. So all patients need HIV tests and 2 ABOs for listing. And this is all on your, on the protocol. There's a few other labs here on the protocol that are just labs that we send off for patients, for any patient who gets listed. So, there's CMV serology and, the quantiferon gold. Those are not really unique to liver failure as much as just for listing patients for transplant. And then the additional tests that you want to order and consults that you need to call are, you need some kind of liver imaging. You can start with an abdominal ultrasound with Doppler. This is important for vascular causes like Budd-Chiari. CT abdomen with contrast and non-contrast scan is not going to help you. This is to look for malignancies or assess for any unrecognized underlying cirrhosis. If they have renal failure, you're not going to be able to give them contrast, and you might just only be able to do the ultrasound. But it's important for the surgeons to know if the portal vein is patent. And then neurologic assessment, head CT, if the patient is encephalopathic. We have neurosurgical intensivists who come to the ICU and help with the neuro assessment. You need to send off an initial infection workup because these patients are so prone to infection. So chest x-ray to rule out pneumonia, blood and urine cultures, which, as an aside, I'll just tell you politically, they're very reluctant to send them from the ICUs here because they don't want to be dinged for a line-associated infection. So sometimes you have to push the ICU to send these cultures off. We have transplant ID teams who will come and leave an ID consult. And then this is really important. There are members of the transplant team who need to be notified sooner rather than later. So a financial coordinator to make sure that these patients have the right kind of insurance coverage. There's an on-call coordinator who will help to list the patient. And then we have transplant social work and transplant psychiatrists who get involved in assessing their psychosocial support and candidacy. Suicidal ideation is not an absolute contraindication to transplant. Some of these patients just haven't been plugged into the right kind of mental health care, and we try to give them the benefit of the doubt and help them address that after transplant. We try to save their life first. The transplant surgeons need to be aware, again, sooner rather than later, and then all these patients get EKG, echo, and a cardiology consult. They're too sick for a stress test. And this is all on your protocol as well. So some diagnostic pearls where your initial labs can be helpful in establishing a diagnosis. So the Tylenol cases tend to have very high AST, ALT levels, but modest bilirubin elevation. If you see a fulminant presentation in a young person with a normal alk-phos level, that's nearly pathognomonic for Wilson's disease, and that's a patient you have to list and transplant ASAP. They will have some of their bilirubin elevation is from hemolytic anemia. So you'll see indirect hyperbilirubinemia that's disproportionately elevated compared to the alk-phos, which will give you a high bilirubin to alk-phos ratio. And then HSV, I don't know why, but it's one of these conditions that can give you a disproportionately normal bilirubin in the face of everything else. I don't know why. Early diagnosis is important for initiating targeted treatment. So for Tylenol toxicity, we give them N-acetylcysteine. There's data to support utility of IV NAC in non-Tylenol cases. The utility is in patients who present with early encephalopathy. If they present late with stage 3 or 4, the horse is out of the barn already. But there's little downside to N-acetylcysteine. Acyclovir may help with HSV cases. And then steroids are a little controversial with autoimmune hepatitis cases. If you catch them early enough, perhaps steroids can turn the course around and obviate a transplant. However, these patients are at such high risk for infection that you may be worsening their risk for infection. So the steroid decision is something that we struggle with as a team. And then if it's one of these pregnancy-related causes, then delivery can be life-saving and also help to avoid a transplant. This is the NAC protocol. If a patient is presenting with Tylenol toxicity early on, sometimes activated charcoal may help, but usually that's something that happens in the ER. There's various different prognostic models. Obviously, we want to avoid transplanting someone who doesn't need it. So there are prognostic models that help to predict mortality without transplant. The King's College criteria are the classic tried and true ones. I'll go through some of these other ones as well. The other predictors of poor outcome without transplant are high arterial ammonia level, high lactate, high phosphate, and low alpha fetoprotein. So if you have liver regeneration, you should be using up ATP and depleting phosphate, and similarly have high AFP levels. This is the King's College criteria. It differs based on acetaminophen versus non-acetaminophen causes, and so if you have acetaminophen causing acute liver failure and you meet these criteria, it's a high mortality without transplant. Non-acetaminophen, the cases that don't do well are idiosyncratic drug-induced Wilson's, and patients who have high bilirubin, or patients who have this kind of subacute presentation where it's a longer lag period between the jaundice to onset of encephalopathy.
Chris, I kind of make a point here. For those fellows, the first criteria is pH, right? Arterial pH. I talk a lot about arterial pH in disease in general, right? So this is something where if you're suspecting ALF in terms of triaging transfer, you need to ask them for arterial pH before they go over. That's something they can do very quickly in the ER. They're not a venous, looking at the bicarb, asking for a blood gas. That'll really help you understand sort of the direction this patient's going to go.
Good point. The Clichy criteria are based on factor 5. Any idea why factor 5 is useful? So your liver produces a lot of clotting factors, and so factor 5 is the one that has the shortest half-life. So low factor 5 levels are a poor prognostic sign. And the EASL guidelines kind of break down all these various different prognostic variables and their sensitivity and specificity. And so the King's College criteria are pretty good. Clichy also pretty good with factor 5 levels. And then MELD is not so great when you compare to some of these other predictors. Alpha fetoprotein also can be pretty sensitive and specific. Okay, so let's go on to clinical management. So these are all the things you want to think about when you're first getting the call, when you're first assessing the patient when they arrive. You want to get to a diagnosis and you want to assess their prognosis. Is this patient going to survive on their own, or do they need to get listed for transplant? The rest of clinical management is a lot of ICU care. So these patients have multi-organ failure. They have cerebral edema, they have cardiovascular dysfunction, they're prone to infection, renal failure as a result of the hemodynamic disarray, as well as sometimes direct toxic effects. And then they have metabolic consequences like hypoglycemia and also coagulopathy because you're not producing the factors. Number one cause of mortality in patients with acute liver failure is cerebral edema. So that's the one thing that we really need to be on the lookout for and try to manage, although our ability to manage cerebral edema is somewhat, and our ways to assess cerebral edema are somewhat crude right now. And then number two cause for mortality is infection and sepsis. So encephalopathy in these patients results from buildup of ammonia. So you need a healthy functioning liver to get rid of ammonia by converting it to urea, and then it gets excreted. So patients who have renal failure are more prone to encephalopathy and cerebral edema. And there's different theories about how cerebral edema develops. One is breakdown of the blood-brain barrier, and then other theories relate to accumulation of ammonia in the astrocytes. So if you have ammonia, it crosses the blood-brain barrier, gets converted to glutamine, which then can't get released from the astrocytes, and then pulls in water through osmotic effects. Another theory is that there's impairment of the sodium-potassium exchange pump, and then you get you get increased intracellular sodium levels and water follows. So this is one reason you want to avoid too many sodium shifts in these patients. And one problem that I see sometimes is aggressive fluid boluses. And so if you have a lot of fluid shifts, that's a problem that can precipitate or cerebral edema in these patients. Jean mentioned all the different stages of hepatic encephalopathy. Once patients get to stage 3 or 4 encephalopathy, they're at very high risk for cerebral edema. So the majority of these patients will develop cerebral edema. So this is why you want to catch patients early on. Once you see some of these later signs, it's probably too late. They're already either developed brainstem herniation or they have impending herniation. So the Cushing reflex is when you get paradoxical systemic hypertension with bradycardia. And then if they're demonstrating any posturing movements or they have loss of pupillary reflexes already, that's too late. So the goal in managing these patients is to maintain cerebral perfusion pressure. So the cerebral perfusion pressure is the difference between your mean arterial pressure and your intracranial pressure. So if your mean arterial pressure drops and you have systemic hypotension, you're not going to have adequate cerebral perfusion pressure. Similarly, if your intracranial pressure increases, that also lowers your cerebral perfusion pressure. So ideally, we would want to have a way to measure intracranial pressure to keep it low enough so that you can maintain the cerebral perfusion pressure. Problem is that we're still working on safe ways to do this. So these patients need frequent neurochecks. You want to try to avoid sedatives early on so that you're able to assess their neurologic status. They should, if anything, be on the higher side of serum sodium levels rather than lower serum sodium levels. And then there's just simple things in the ICU that can also help keeping the head of the bed elevated, avoiding suction and noxious stimuli, trying to avoid transporting them up and down too much for testing. I only realized this recently, but there's a portable head CT scanner in the neuro ICU, so sometimes they can even bring that head CT scanner over to the TICU. And then sometimes you can use mannitol, although without any kind of intracranial pressure monitoring, you really don't have anything to follow with the mannitol. And they need to have preserved kidney function, be able to urinate. Yeah.
Have you, like, some of the cases are kind of borderline, like, you know, very sick, but you don't have a pressure monitor. Like, have you used mannitol as like prophylaxis before the patient is really moving toward that? You know
Yeah. Yeah.
Like, what is the exact indication for mannitol? Because a lot of times these patients are intubated and just very sick.
Right.
And we don't have a monitor.
Right.
So for some of those patients, like, what is your recommendation?
I mean, I haven't used it, and I haven't seen it used in the literature outside of alongside ICP monitoring.
I've seen them use it for with like follow pupillometry and looking at like optic nerve sheath diameters just as like a surrogate. So if it starts to change, then they'll give it, but it's rare, you know. It's when someone has other stuff as a way.
Yeah. So we'll talk.
Prophylactically, I've seen them do saline.
Yeah.
Raise their
Yeah. So the hypertonic saline, there's some limited support. Hypothermia also some limited, but you know, again, you're not going to find a lot of randomized trials in the literature. ICP monitors have been fraught with controversy. The problem is it's an invasive procedure that's associated with bleeding risk. So this is the data from the acute liver failure study group where they surveyed transplant centers and use of ICP monitor. And you can see only 22% of cases involved use of an ICP monitor. So most places don't use it. And in this study, they were looking at 21-day mortality. And of the patients who used an ICP monitor where there was data available on safety, there were 3 deaths due to hemorrhagic complications, so 3 deaths out of 56. Conversely, though, in non-monitor controls, there were 13% who died due to cerebral edema. So, you know, sort of apples and oranges. You can say if you have the ICP monitor and they don't develop a bleeding complication, maybe there's some benefit to using it. However, when they looked at 21-day mortality, there was no survival benefit in Tylenol cases, and there was actually increased mortality in the non-Tylenol cases with a odds ratio of 3 for mortality. Jim mentioned some alternatives to ICP monitoring, given that we're concerned about bleeding complications. So this is the protocol that we use here at Sinai. So neuro exams, pupillary exams, CT head, but we have a series of non-invasive surrogates for elevated intracranial pressure that have been adopted from the neuro ICU literature, and these have not been validated in acute liver failure patients, so it's an ongoing study. Alexandra Reynolds came and gave a talk, hopefully that she can give again this year, which explained all this stuff in a bit more detail. I'm only going to skim over this, but one non-invasive surrogate is something called pupillometry. So the problem with assessing pupil reactivity is, you have to turn the lights down. There's a lot of subjectiveness. You can say, yeah, reactive, non-reactive, sluggish. What the pupillometer does is it's a handheld device that takes an image and measures, does objective measurements of the pupil reactivity. So this comes from a publication from Alexandra along with Dr. Schiano. It's actually going to come out in hepatology about non-invasive neuromonitoring in ALF patients. And so it's just an example of what the pupillometer looks like. If you go to the flow sheet spot in EPIC, it will report out the pupillometry readings in these patients who are in the TICU.
The nurses do that, right?
The nurses do them, yeah. Mm-hmm. Yeah. Another way to non-invasively assess ICP is the optic nerve sheath diameter. So the optic nerve is in continuity with the dura, and so when your intracranial pressure increases, your optic nerve diameter increases, and so the diameter will be increased in patients with elevated ICP. This is based on ultrasound that's placed over the orbit, and this is also reported out in the flow sheet. This is the suggested triggers to prompt a head CT. So if you see changes in the Glasgow Coma scale, low reactivity on the pupillometer, new difference in pupil size, new seizure activity, new asymmetric weakness. The neuro ICU team comes and helps along with assessment. So they're kind of doing all this in parallel and helping to guide us when these patients come to the TICU. So this is what we do here at Sinai. If you look at the EASL recommendations, it's all kind of grade 2 evidence, and you can read through this in the in the review article, but they basically say consider ICP monitoring, particularly in the Tylenol cases and young patients or patients who have high ammonia levels. And then, patients with low-grade encephalopathy need to be monitored frequently. And then patients who progress to grade 3 are ones who need to be intubated. Again, though, patients who are at an outside hospital with early grade 1 to 2 have a low threshold to intubate them before they come over. The EASL doesn't comment on pupillometry or optic nerve sheath diameter, but they do reference transcranial Doppler, which is another way to assess ICP monitoring, and we can do that here as well. So I'm going to try to skip through these quickly. So infection and sepsis is the second leading cause of mortality. Risk increases with time spent in the ICU. These are patients who are getting frequent lines. Later on, fungal infections. Fungal infections are also higher in patients who are on renal therapy, so renal replacement therapy. So low threshold to initiate prophylactic antibiotics. However, there's not a lot of strong evidence that prophylactic antibiotics improves their outcome. Coagulopathy is a problem with these patients. They have not only deficiencies in the liver-produced factors, but they also have abnormalities in platelet function. Don't be fooled if you see low platelets in these patients. These acute liver failure patients can have low platelet counts on presentation in the absence of underlying cirrhosis. And I think the important point here, which is reiterated by the EASL guidelines, is you don't prophylactically give these patients FFP. It's important to monitor the INR for prognostic purposes. You can give it to them if they need it for line placement. These patients have a lot of hemodynamic disarray. They have high cardiac output, low systemic and systemic vascular resistance. So these are patients who will often need pressor support. Which one you choose is not based on a lot of strong evidence. So we usually defer to the ICU team. Volume management can be really tricky. A lot of these patients are volume deplete and do need fluid resuscitation, but again, be careful about the sodium shifts and avoid over-resuscitation. And then ventilate and intubate patients who present with early encephalopathy. Renal failure is very common. Sometimes it's direct nephrotoxicity, particularly Tylenol cases. Sometimes it's hepatorenal syndrome. There's not a lot of strong evidence for when to start CVVH. Different centers have different thresholds. In our protocol, we sort of say we'll address it on a case-by-case basis. There is some evidence in the literature to support early CVVH in patients who have high ammonia levels. But this is grade 3 evidence. And then don't forget about the metabolic disarray that patients can present with. So they have defective gluconeogenesis and often need extra dextrose in their IV solution. So EASL, in terms of target sodium levels, recommends targeting sodium levels on a somewhat higher side, and this is based on level 2 evidence. So just a quick note on outcomes. In general, these patients don't do as well after transplant compared to patients transplanted for chronic disease. However, that kind of evens out later on. These are poor prognostic signs for poor post-transplant outcomes. So patients who have renal failure or are higher in the spectrum of age or BMI. And the patients who don't have these poor prognostic signs, so young patients who haven't yet started dialysis, tend to do the best. And then as you increase these risk factors, the post-transplant survival decreases. Okay. You want to just go through some quick cases? And these are all real cases. So this is a 19-year-old woman, prior history of depression. She's had some past suicide attempts. She broke up with her boyfriend on a Saturday afternoon and took 300 Tylenol PM tablets. So if you kind of add them up, a Tylenol PM tablet has 500 milligrams, so that's a total of 15 grams. Do you guys have a sense of how much Tylenol is required to cause liver failure? Yeah, about 10 or so, 10 grams. Because it's one of these predictable dose-dependent toxins, right? So she presented to the ER 2 hours later. She got charcoal. Her initial labs didn't look too bad. AST, ALT in the 40s and 30s. Bilirubin was normal. INR 1.1. Tylenol levels elevated. They started her on NAC. Mental status-wise, she started to get a little bit agitated, and then they called when her labs started to get worse. So 2 days later, AST 600, ALT 800. Bilirubin not that high, again, kind of this is what we see in the Tylenol cases. INR 3, and now her ammonia is starting to rise. So we transfer her over to the ICU. She's lethargic. She did not get intubated prior to transfer. She was a little lethargic. And then we did a rapid workup and listed her 12 hours after she presented. Her AST, ALT continued to go up. INR rose. She developed worsening agitation, got intubated. Fortunately, the head CT didn't show any cerebral edema. But this kind of shows you this hyperacute presentation where their INR gets really high and they develop encephalopathy. AST, ALT continued to go up. We're still waiting for an organ offer. INR is 11 now. Lactate's rising. And then fortunately she got an organ offer and got transplanted. So this is a case where it was to her benefit to come over and get listed in a timely manner. I have 2 more cases. So this is another case, a 25-year-old woman. She has unremarkable past medical history, no underlying diseases. 2 weeks prior to presentation, was taking some ibuprofen for wisdom tooth pain, and she took it for about a week and then stopped. She went to see a local GI provider. She didn't really have a PCP, just went straight to a GI for abdominal discomfort. And they gave her a PPI. They ordered an abdominal ultrasound. They probably sent labs, although we didn't have that when she presented. And then in the ER, she had these labs on presentation: INR of 8, pH of 7. So this kind of goes to Jean's point about having the presenting pH, and a lactate of 19. Any thoughts here? What's that? Maybe a dilly from antibiotics. Yeah, maybe she was taking that for the wisdom tooth pain. Maybe alcohol and Tylenol. So they started some workup. They did a CT abdomen without contrast. She had some fatty liver. She was a little obese, borderline spleen size, moderate ascites. What's that? Why are you thinking about thrombosis? That's a good point. Yeah, that's a good point. Viral labs were negative. A tox screen and alcohol level was sent off. It was negative, although just take some cannabinoids. And then she got intubated prior to transfer in the setting of this low pH and acidosis. She was a little lethargic around that time. She's one of these cases where she got started on pressors, and we were really concerned about how to get her over here safely. And then on review of systems, she denied any herbal use, hadn't been taking antibiotics along with this tooth pain. The Tylenol level was non-detectable on admission, although she had stopped it 1 week prior to presenting. No recent fever or travel. And then in the waiting room, the family was very concerned. They were all trying to ask if they could donate. And there's like this waiting room of like 20 family members, and like she's intubated, you can't get any history from her. And we're talking to the family, and any family history of liver disease, and like the brother says, "Oh, I had I had Budd-Chiari syndrome a few years ago, and they told me I have antiphospholipid antibody." Are you taking anything? No, I stopped. So that was an important part of her family history. And her mother has a history of autoimmune disease, lupus and scleroderma, and her mom had actually passed away 3 years prior. Any thoughts now? Acute Budd-Chiari. Yeah, now we're really wishing that they had done an ultrasound before she came over, or like did contrast with the CT scan. On arrival, she's intubated, no stigmata of chronic liver disease. She's nodding her head, opening eyes. These are her labs when she arrives, AST, ALT in the thousands. She's in some renal failure, INR is rising, lactate still high, fibrinogen's dropping, pH corrected after intubation. AFP is low, yeah, not a good sign. And finally, she gets a bedside ultrasound, and there's no flow in the hepatic vein, an enlarged liver, and some mild ascites. What are you guys thinking now? Sounds like Budd-Chiari, yeah. So Kieran, you were right on point with the abdominal pain and ascites. So she was listed on arrival, and fortunately she got an organ offer and was transplanted. All right. We're kind of over time. Should we go? Okay, this is one last good case. All right, 54-year-old woman. She's a home attendant, tested positive on a routine annual PPD, and got started on isoniazid, and this is back in March. This is March of this year. This is a case from just recently. She kept taking the INH, wasn't asked to go back to her PCP. started to see some dark urine, went back to the PCP. This is 3 months after she had started the INH, and her labs show elevated LFTs. The PCP sent her to the ER. These are her labs on presentation. Her Billy's 30, INR 2.6, normal creatinine. No recent travel, viral labs unremarkable, no other underlying liver disease, and she's alert and appropriate, no stigmata of chronic liver disease. So this sounds like, I mean, no mystery here, this is INH toxicity, right? So we bring her over, she gets admitted to the floor because she doesn't have encephalopathy. We do a rapid transplant workup. She meets the INR criteria. Her fibrinogen is okay on initial presentation, but starts to drop. Her bilirubin stays in the 30s. Her alpha fetoprotein actually is like a little bit elevated. And the problem with her is that she never really had encephalopathy. So we watched her every day. We had her like do kind of early encephalopathy testing, like the serial 7s and all that kind of stuff. And finally on hospital day 5, and I will say this is, I don't know, we kind of went a little bit out on a limb with her. She had no real asterixis, but when she was drinking from her cup, she was shaking. So we just said, okay, we'll call that asterixis. We put her in the TICU. The problem, to Jean's point, though, is that everyone else was writing in the chart, no encephalopathy, alert and oriented, well-appearing. But we said, nope, we're calling this encephalopathy. We listed her. She went to the ICU on a Saturday, and while there, was alert, well-appearing. Sunday, her family noticed she was a little sleepy, although the staff didn't pick up on this. Later that night, she was intubated. She got started on CVVH, pressors. We just threw the kitchen sink at her in terms of antibiotics. And then she waited and waited and waited 5 days with no organ offers. And she passed away without an organ offer. So this is a really sad, unfortunate case of INH toxicity. It was probably completely avoidable and argues for listing these patients before they have these overt signs of encephalopathy. All right. So just to sum up, mortality from ALF remains high. Early diagnosis, early transfer is vital. Remember, prognosis varies depending on etiology. Cerebral edema is the #1 cause of mortality. Watch for infection, #2 cause. And timely transplant can be life-saving for these patients. Okay. All right. Thank you.